really excited to be joined today by Dr. Zoe Berger, who's a consultant clinical psychologist based at St George's Hospital. I'm sure she'll tell you a bit more about herself as well. She actually spoke on our webinar series last year, and people asked for more of her. So by popular demand, we've got Zoe back, and she's got a whole hour this time to talk to you. We've had a few problems with slide sharing today, so this view that you see is the best we can do, I'm afraid, in terms of the slides, but hopefully that you'll be able to see enough as Zoe talks through the slides as well. So welcome, Zoe, and thank you so much for joining us.
Thank you. It's really good to be here, and like you say, it's nice to be back. A lot of people who may have heard me last time, some of this will be a bit of a repetition, but it's always good to have a bit of time to think about how we can look after ourselves, I think. So yeah, just you've already done a really nice introduction. Just in terms of context, I head up the paediatric psychological therapy service here at St George's, and outside of my NHS work, or alongside my NHS work, I should say, I've kind of been involved in writing the national guidelines around post-event team reflection, so a term that we're using instead of the word debrief. And I also work with the Point of Care Foundation as a mentor, so thinking much more about how we deliver compassionate care in healthcare settings. So my hope really for today is for us to spend a bit of time, or for me to be spending a bit of time, just setting the scene, highlighting the importance of supporting staff. This will be very familiar. I don't think I'm going to be telling you anything new, but certainly in the context that we live in at the moment in the NHS, just why it's so important. I'm going to think a little bit about burnout, moral distress and trauma, and then spend a bit of time sharing with you, I guess, the neurobiology of how we respond to stressful events, so that we can really understand the reactions that we have, the very normal and understandable reactions that we have to stressful events. I'm going to spend a bit of time debunking the myths that exist around debriefs, of which there are many, and think about post-event team reflection particularly, which is a term that we're using to describe a form of psychological debrief. I'm going to think with you about some different approaches to staff support more broadly, and then I want to share these ideas that come from the King's Fund around autonomy, belonging and contribution, which is really about how we create workplaces that support well-being. And like I say, if you've heard me before, some of this will be familiar, but I think it's always important to have a bit of time to consider how we create the context contexts that allow us to kind of work well and manage stressful events. So in terms of what the webinar is based on, slightly shameless plug here, but this is the good practice guidelines that the webinar is based on, the group psychological debriefs, which I've wrote with a number of colleagues that work in different acute settings across the country. And for those who haven't seen this book, I'd really recommend it. It's got a huge variety of different chapters that cover staff support in healthcare context in different ways, but certainly recommend having a look at some of the chapters in that. So why does caring for ourselves matter? Maybe sounds like a stupid question to be asking, but certainly given the current state of the NHS, it's not just, is it, the increased medical complexity, the exposure that we have from working alongside the challenges we get from social media, long stay families, traumatized families, our increase in workload, but there's certainly the financial pressures that we also have to live alongside. And I'm sure many of you on this call will be navigating a huge amount of that, thinking a lot about SIP plans and how to deliver deliver more with less, and certainly the sense of increasingly finding it hard to have a common sense of purpose. And I think in that context, it's sort of inevitable that the levels of stress in the NHS today are pretty high. And so there's a question, I guess, why is it even important? We know that the context is such that the stress is inevitable, but it's the right thing to do. It's embedded in the NHS constitution to support staff, very clearly outlines that respecting dignity and compassion should be at the core of how we treat patients, but also how we treat staff. But it's replicated time and time and again that there's a link between staff wellbeing, sickness rates and retention, and it impacts on patient care. And that's information that you will be familiar with. It's not going to be news to you, but it feels really important just to reiterate it here. I wanted to share some of the numbers, and they're numbers that many of you, I'm sure, will have seen, and I guess are quite striking when you look at them just in their like real terms. So in January this year, the NHS sickness absence rate reached its highest yet, so almost 6%. A quarter of the 6 days that were recorded were due to anxiety, stress, and other mental health challenges. And half of NHS staff that were surveyed reported feeling unwell due to work-related stress. And I don't know, maybe don't know if that fits with your sense of what's going on in the organisations that you work in, but I guess they feel quite stark numbers. And I was looking at a recent report, and it looked like 43,500 nurse vacancies were currently around in the UK. And so it's not really surprising, I suppose, that there are a lot of media reports of people in the NHS feeling broken or on their knees and exhausted. I wanted to say something about, I'm sorry that this slide is not looking as we'd like it to, but the reason I wanted to share this was because I wanted to think specifically about these three different aspects of work-related stress. So there's burnout, moral distress, and post-traumatic stress, and they're terms that I'm sure you will have heard and will have been bandied around many times. And this is a piece of research that it's quite old now. It was conducted pre-COVID in 2017 by Gillian Colville, who was actually my predecessor here, looking at staff burnout and stress particularly in intensive care units. And I guess the important bit of what she found in this large-scale survey was that there was this overlapping yet distinct nature of work-related stress, but there was no association between these things and gender, no association between people's experiences of burnout, moral distress, and post-traumatic stress and their length of service, their role. There was some association between staff that were directly involved in patient care being at the highest risk of moral distress and PTSD, and the larger the unit size, that was also associated with higher moral distress and burnout. But it's important, we're talking about high numbers of staff experiencing some form of work-related stress, and it kind of often we think about the events that are perhaps around traumatic death or the end of life care for some young people, but I think that there are a number of examples of clinical encounters that are perhaps not so kind of high profile, but still have the same kind of profound effect on members of staff. So some of these examples that come to light these are parts of conversations that I've had with nursing staff and with other members of the MDT that around clinical encounters that they find particularly difficult, distressing, stressful. And it may be something like a distressing patient transfer, some questions about some moral, ethical dilemmas about whether or not new or experimental treatment should be pursued, or if life-sustaining treatment should be withdrawn. But there are also these smaller, more relational judgments that people are confronted with on a regular basis. So which call bell to answer first, which aspect of care gets prioritised or drops slightly lower down the list, or perhaps has to get handed over at the end of a shift. And certainly issues around lack of continuity of care or poor communication are some of the kind of examples in day-to-day clinical practice that really have a profound effect on staff members. And we know that all of that is heightened when there's conflict between a family member about what should be done and about the kind of course of the clinical treatment. So I guess what we're saying is that the context is ripe for work-related stress and potentially for trauma. There's a question then about what can we do about it, particularly as leaders and as managers in the system. But there's also a question for me about, well, what's the role of reflective practice here, and why particularly might I be advocating that reflective practice could happen or should be happening in groups? And I kind of want to point us to some of the King's Fund research. So Michael West has done lots of research looking extensively at NHS teams and what helps them to perform well. And one of the things that he and they consistently have found that high functioning teams are those that have regular scheduled time to reflect together. So there's something about the coming together to think about the work that they are doing collectively that it is a protective factor in terms of being of well-being, but also helps the team to be higher functioning. And we know, as I've said kind of alluded to, but there is this link between high functioning teams and patient outcomes. That's fairly unequivocal, that higher function teams have better staff engagement, better communication, better attention, lower patient safety incidents, and ultimately better patient experience. So I guess I'm proposing this idea, perhaps not uncontroversially, that we should be framing reflective practice probably as essential rather than optional, especially in these kind of high pressured environments. So we know that coming together supports emotional processing, professional growth, that it can enhance clinical decision making, can reduce the burnout and moral distress felt by staff teams, and it can promote this kind of sense of connection and shared understanding. And shown is another person that talks a lot in this field, and they talk about these kind of complex real world problems that we have to face, particularly in healthcare. So he talks about the swampy lowlands versus the higher ground. And so for him, higher ground represents these problems that are relatively clear cut, they're technical, they're probably quite easy to define, whereas the swampy lowlands are where professionals are having to deal with uncertainty, conflicting values, ambiguous information, sort of ethical dilemmas. And we often find ourselves in those kind of swampy lowlands, I think, in healthcare. So for Schoen, what he's proposing is that there's a space to reflect on action. So we can reflect in action, which is in the moment. That's a more personal experience where we're deciding how we act in any one moment. But reflection on action is a group endeavour and really helps us to kind of come together with a sense of connection, shared understanding, but helps in this continual cycle of learning. I kind of want to pause there a little bit, and I want to spend a few minutes just thinking with you about stress and trauma, and I guess more importantly what's happening in our bodies and our brains when we're exposed to distressing and or stressing events at work, really to help us make sense of our emotional responses and also to kind of normalize, I think, many of the kind of physical and emotional experiences we have when we're faced with some of the pressures that we experience in the workplace. I'm sure some of you will have seen this slide before, but I guess why I'm showing it is because I want us to think about what's happening in our brains when we're confronted with something that we find stressful or distressing. And we know that our brains are designed for survival and not for happiness. So over millions of years, our brains have evolved to become much, much more sophisticated, but we do still rely very, very heavily on our old ancestral brains that are kind of responsible for the fight-flight responses that we that promote survival, but that we have when we are confronted with something that's particularly distressing or stressful. So when we feel under threat, our old brain ramps up deep in our kind of amygdala, and it takes over, and it produces very powerful feelings of fear or shame, anxiety, disgust, all of which are hugely helpful for our survival. And then our new brain can kick in a slightly later, further on down the line, which allows us to kind of analyze or think about those feelings. But so at one level, our new brains, our evolved frontal lobes, are incredibly helpful because it allows us to plan, self-monitor, design planes, get new medical advances. They're incredibly helpful, but it can also hugely trip us up because it allows us to have this tendency to get into being quite self-critical, to ruminate, or to worry about things that have happened historically, or that things that may happen in the future. So I don't know if people can connect to this particular graph, but I quite like the simplicity of it in some senses, and I appreciate that I am simplifying hugely complex brain processes, but if you bear with me, I think it's the message that I suppose I want to convey. If you look at that zebra that's potentially grazing in the wild, in the savannah, enjoying just a moment to itself, it hears a startle response, hears a kind of noise in the background, a twig breaking or some movement in the bush, you'll have a startle response. It has a very quick response. Its old brain kicks in. The emotion level is high. When it looks around and it realizes there's no immediate threat or danger, very quickly that emotion level will drop back down again, and you'll see that zebra going back or resuming its grazing, or it's kind of able to kind of spend some time nuzzling or being with other zebras quite at ease. In contrast, when we think about what happens to us when we're confronted with something that we find stressful or distressing, if we think about particularly at work, we might have that same startle response. We'll feel our heart racing, our muscles will tense, we'll feel anxious. But the downside is that our new brain quickly kicks in, and that means that we find ourselves dwelling on the event that might have happened. We might find ourselves imagining the worst case outcome, or getting into being quite self-criticizing. So, for example, and I use this example a lot, so I need to find something newer. So I apologize if you've heard me say it before, but a really good example that I hear nurses talk about a lot is whether or not they've locked the medicine cabinet and they find themselves getting to the end of the shift, or they're on their journey home and they're thinking, oh my gosh, did I do that? And they'll replay the scenario in their head. They'll desperately try and remember whether or not they did or they didn't. They get into worrying that they're likely to get told off. They'll retrace their steps. They'll be thinking about it a lot. Perhaps they'll project into the future thinking, oh my gosh, they'll think my team are going to think I'm absolutely useless. I'm going to potentially lose my pin. So there's a capacity to catastrophize, to worry, to ruminate, to get into being quite self-critical, which keeps the emotion level high for much longer periods of time. It's much harder. We have to work much harder to bring that emotion level down, to be able to park the event for the day and kind of be able to get into a state in which we're able to relax again. And I suppose the reason I show this graph is because I think if we recognize that we're potentially confronted with stressful or distressing events multiple times over the course of the day, it's no wonder that our emotional level remains high for much longer periods of the day. Alongside that, I think it's important to say something about how our memories are stored, because I think it's also an important part of the picture, particularly when we're talking about traumatic events. So it's really helpful to use this factory analogy. So if we think about bits or chunks of information that gets processed over the course of the day, memories for events that have happened can enter into our kind of factory, into our brain, and be processed and stored. They get filed away and they get a date stamp. So we know what we ate for breakfast this morning. If I was to ask you where you went on holiday over the summer, you'd be able to tell me, you know what happened and you know how it felt. Those bits of events, memories for everyday events are processed with a timestamp very easily within our brain, in our factory, if you want to call it that. But if something bigger happens, or something unexpected or difficult happens, particularly something that's got high emotion attached to it, where our amygdala has taken over, we know that our old brain has kicked in, our amygdala is fired up, and our feeling center of the brain has taken over, which means that our brain finds it much harder to process it. We tend to not process the information with a date stamp. As such, we don't think about it in its entirety. We tend to just encode and store very rich detail. It tends to be very sensory detail. So it might be things like what things smelt like or sounded like, the noises in the room, what people, the temperature, what people felt or physically, as well as what was going on around them, but not the detail that allows you to kind of process it naturally, just those kind of very sensory bits of information. And the problem with that is it means that because we haven't got a timestamp, but we've got lots of sensory bits of information being processed without the kind of narrative that goes alongside it, it's much more likely to mean that we remain on high alert. So the event then can cause lots of emotional distress, but it can also trigger flashbacks where the person can kind of relive and re-experience the emotions and sensations from that moment. And I often use this analogy. Again, it's another one of my analogies about a laundry cupboard. And again, people may have heard this before, but just useful to kind of bring in here. I think if we were to think about our brains a bit like these linen cupboards that are on the screen at the moment, I don't know what it looks like in your house, but mine is much more the image on the left than on the right. But if we think about a distressing event that's happened, our brains aren't able to process it. It's not neatly stored away. It's pushed in or shoved in various different ways. And we have an experience in which then there's always this sense that those memories or those experiences are likely to tumble out, and quite possibly they will tumble out because there's no way that cupboard door is going to be able to close very easily. So we don't like the experience of those memories coming back in. We don't like the experience of flashbacks or reliving certain experiences that we might have had, and so we desperately try and avoid that happening. So we're pushing back all the time on that cupboard door, hoping desperately that it doesn't swing open and all the bits come tumbling out. But it doesn't take much for our cupboard doors to swing open and for all of the bits and the memories to come tumbling out. It might be that we walk into a similar environment, somebody says something to us, there's a smell or a sound that is very triggering for us, and because we haven't stored those memories neatly away in our brain in a time-stamped way, the cupboard door swings open and it all kind of comes back. We have that experience of reliving the event. And so in an ideal world, we had the opportunity to process what we've been through, to be able to take out the experiences, sort of air them, quite literally look at them, fold them up neatly and put them away so that the linen cupboard looks much more like the one on the right hand side. And we normally do this. We have a huge capacity as humans to be able to go from the left-hand cupboard to the right-hand cupboard very naturally. It tends to come through acknowledging what we've been through, talking about it. Usually we do it automatically with friends or families or colleagues. We might do it at the end of a shift, or we might do it kind of in our breaks. We might do it at the end of the day. But there are times where I guess that the event feels too big or too difficult and we might need a bit of extra support. And it's knowing, I guess, both individually, but also as leaders and managers, when members of our team are struggling and we need to kind of put in the extra support. I wanted to just give this definition of trauma because I'm using the word trauma and we talk a lot about PTSD. That's a term that we're much more familiar with now in healthcare settings. But the reason I'm putting this particular slide in is because I want us to think about the expanded definition of trauma that's come with the change from DSM-4 to DSM-5, which is our diagnostic manuals when we're looking at making decisions about whether or not somebody's experiencing a PTSD or reaches threshold for a PTSD diagnosis. And the reason why an expanded or a broadened definition is important because it's really relevant for healthcare staff. So it includes not just being exposed to actual or threatened death or serious injury, but being witness to it in person. So witnessing in person the event occurring to others, but also experiencing repeated or extreme exposure to aversive details of such events. So, for example, with first responders. So the broadened definition allows us to recognise much more formally, I guess, that healthcare workers that are exposed to distressing and stressful events may be more at risk of developing PTSD or certainly experiencing a traumatic response. So what can we do? We've talked about the context. We've talked about the way that we respond to trauma and stress neurobiologically, and I guess in this section, what I want to do is focus on what can we do to cope, both ourselves, like gain an awareness of what's happening in our bodies, but so that can help us individually cope, but also think importantly about how we set up structures for our teams so that they can also manage these kind of situations. And this is where I guess the question is, like, how do we support staff in these environments? And as I've already said, we know that they might be frequently exposed to distressing events, but it doesn't necessarily mean that every single event is going to require some kind of psychological or staff support intervention. Like I've said before, many of us are going to be able to process the stuff we come across in our work days without, naturally, we'll be able to do that without any additional support. But it is useful for us to find ways in the kind of work context that we are in to help staff to come together to foster this sense of calm, connection and hope, which is with the aim not to be necessarily to prevent PTSD, but to foster this ability for people to have this peer-to-peer support and capacity, enhanced capacity to process what they're experiencing day to day. If this could be a bit more interactive, I'd invite people to kind of comment on whether or not they've come across this model before, because I think it's a really helpful model that talks about our emotional regulatory systems that are at play and that can be activated in our brain, both by aspects of our work and also aspects of our life. And I've talked about the threat system already, that system that we have that is powerful for our survival. But we also have two other systems that are that can be activated in our brains at any one time. And one is the drive system, which is important to think about, which is our seeking system. It motivates us towards our resources. It helps us to feel motivated, engaged, focused. We also have a soothing system, which is the system that helps us to manage our distress. And it's a system that helps us to promote kind of bonding, a sense of feeling connected, safe and cared for. And when I talk with people in healthcare settings, we talk a lot about the amount that our threat system is activated. And we know that by thinking, if I was just to invite you to reflect on the day that you've had so far, the things that you've navigated, even just coming to this lunchtime webinar, my guess is that a large amount of those different events that you've had to deal with today will have activated your threat system. Maybe it's activated your drive system, if you're lucky, a bit of soothing, but largely most people say to me that they find that their threat system is activated for a large chunk of the day. And if we're thinking about that for ourselves, and then we think about how that applies to our teams, it's really important for us as leaders, I think, to hold this model in mind. What we know can be really helpful is to stop, to slow down, to pay attention to where we are, but also to think about how we switch on other systems in order to counterbalance the impact of the threat system. So I'm going to just invite you for just one moment, really, to yourself as a point of reflection. I just want you to think about what the risk is of being in threat mode. So what happens to you personally when threat mode is activated? How do you feel? How do you act? What do you think the impact is on others of you being in threat mode? And what happens, importantly, to compassion? It's just a moment to think about that question for yourself. I think it's helpful for us to think about it. How do we feel when we're in threat mode? How do we act? What's the impact it has on others? And what happens to compassion when threat mode is activated? And like I said at the beginning of this section, it's really important that we, for ourselves, but also as leaders and managers of teams, are able to stop, to slow down, take a breath, to kind of be able to get into a position in which we observe what's happening in our body, noticing how you're feeling, what it is that you're reacting to, be able to pull back to see the bigger picture, potentially thinking about what someone else might say to you right now, what advice might a friend give me in this moment, and then move forward practicing what fits with your values. And I think it's a really small practice at an individual level, but I think if we can do that for ourselves, then it also enables us to help support our staff to do something very similar. Alongside that, we know that it can be really helpful to switch on these other systems. So holding in mind those models of threat, drive and soothe, what are the things that I can do at an individual level, but also I can think about doing at a team level that's going to enable the switching on of other systems to counteract the impact of threat. So that might be about thinking around, at a personal level, what interests, motivates, excites you, either in your personal life or in your work life. What's your drive to keep going at work? What's connecting you to your values? How do you stay connected to your strengths and your achievements? But then there's other bits that are connected to soothing. So what are the ways in which you do feel like cared for, looked after, connected to other people around you? How are the ways in which you take breaks when you're busy? What are the ways that you build in moments of calm or relaxation? And then most importantly, how you talk to yourself. So I said right at the beginning that our frontal lobes are really brilliant for many things, but they can also trip us up because they can get into very quickly becoming critical of ourselves. And so there's something about how we develop compassion for ourselves, which then also enables us to hold compassion for others. So what I'd really like you to do is, and it may not be now, it may be something that you do in your, when you go away from having listened to this webinar and have a few moments, just to think about what can I do to promote soothing? How can I activate drive for myself or in my teams? And what effect would it have on people in your team if you were to find moments in which soothing systems could be activated for people you work with, and or drive systems could be more activated in order to counter the effects of threat? So just a few moments just to kind of begin to ponder those questions, really. How can I switch on other systems, both for myself, but also for the team, the teams that I lead and manage? The last part of, or the latter part of this webinar, I really want to focus on the role of post-event reflection, and I'm going to talk about that in terms of actually psychological debriefs and how we can embed them into practice, but how that also sits as part of a broader system of support and the importance of developing a broader system of support in order for these psychological debriefs to be really most effective when we're talking about complex and challenging situations in the workforce. And I don't know what word or image or phrase comes to mind when you think of the word debrief. For me, I hold these two images in my mind. On the right-hand side, I absolutely, and there definitely are moments when psychological debriefs that I've been involved in look a bit more like this amazing symphony orchestra. People have come together, they've been able to share their story, they've been able to connect back to their common sense of purpose, their values. They come away with a clearer narrative of what's happened and a sense of hope and connectedness both to each other and to their work. Perhaps more often, it's a little bit more like the garage band on the left-hand side, that people are creating something, but it's perhaps not the kind of magic that we might have hoped for initially. And very, very rarely, there's this kind of, oh my gosh, is it just crowd control? And I think, sadly, a lot of people, when they think about debriefs, kind of have more of this image in mind, a slight worry about what it will mean to be like everybody coming together to talk about something that's difficult. And certainly there's been a number of controversies, and I'm going to go on and just debunk those myths a little bit about debriefing. So I'm kind of curious, and again, if this is interactive, I'd ask you a bit more about what are the images and thoughts and ideas that show up for you when I use the word debrief. And I'm hoping it's more like these first two pictures than it is the latter. But I'm guessing that there will be some of you listening to this that think it's a bit more like this. But what do we mean by debriefing? And I think the main problem that we've had over the years is that there's really no universal definition of debriefing. It's lots of different processes end up getting called the same thing, and you'll hear words and terms being used interchangeably, which is problematic, certainly problematic from a research perspective, but it's also problematic in terms of what is it that teams might be asking for, and what is it that ultimately we might need to deliver. So there's lots of terms like hot debriefs, performance debriefs, cold debriefs, critical incident stress debriefing, which is a model in and of itself. I guess the essence is that all of these different, I mean, also people say that they're going to have a debrief when they're just meaning they're going to have a chat in the team room, or they're going to go down to the pub after work. So I guess the intention is different and the purpose is different with all these different kind of opportunities for people to come together, all with different processes, with slightly different intentions and purposes, but they tend to use the same term, and that's where we're running into difficulties. We also have a whole lot of difficulties that have come from the NICE guidance, which was published back in 2018, or the original NICE guidance, I should say. It's not. It's now been tweaked more recently, but I guess the issue that we had was that after a big review, there was looked at various different research. That was a Cochrane review that was looking at various different research that was out there, ended up suggesting that there was no evidence that debriefing prevented or reduced the incidence of PTSD. And in some cases, there was a suggestion that it may increase risk of PTSD. And so the recommendations in the NICE guidelines in 2018 was that to not offer psychological debriefs. And there's been lots of further exploration since that time. But I guess that guidance really sort of put a stop to any kind of further. Well, people became very concerned and worried about offering debriefing, but they also meant that there was no research or further exploration about looking at what it actually meant, or what was actually the detail of the research studies that were looked at in the original review. And I'm pleased to say that has at least now been explored in a bit more detail. What they ended up finding was that actually a lot of the research was reliant on individual people who'd had events happening to them, for example, road traffic accidents. So they weren't involved in the same incident, they were involved in their own individual incident, were brought together to debrief as a group. And so, of course, what ended up happening was that there was some re-traumatizing by people sharing their own individual stories, rather than thinking about what we talk about in healthcare settings, where a group of people are coming together around the same event. So I guess what I'm trying to say is that there's I feel like there's been some sense in which we've come full circle. We are in a very different position to where we were back when those NICE guidelines were originally written. I think there's a recognition, there's a much more nuanced picture, and that there is some really good evidence that debriefing, psychological debriefing, can be helpful in a primed population. So that means in a group of people like first responders, where they're expecting, as part of their day-to-day work, to be exposed to potentially traumatic events. We also have a better understanding that it's not necessarily one model, but there are 5 key elements that are fairly essential to be part of a psychological debrief, and I'm going to talk about them in a bit more detail. So whilst we do need some more evidence specifically in healthcare, Richards did this nice review in 2019 that looked at early interventions in mass trauma, and found that there was really quite an important role for group interventions when we're talking about a group of individuals that have experienced the same event, and that the most significant benefit comes when it's part of this broader programme of support. And that's where this framework, so PETRs is what we call them, post-event team reflection, where this framework for post-event team reflection came from. And what are we trying to do in a PETR? We're really drawing on these 5 key elements, these 5 principles that Hobfeld talks about in his paper, which has ultimately over time formed the principles of psychological first aid. And like I say, there's some good empirical evidence that these 5 factors are really useful when we're thinking about mass trauma intervention, and can be applied in situations in healthcare where groups of individuals have experienced the same event and want to come together to talk about it. So these 5 principles are around creating safety, a sense of calmness, self and group efficacy, i.e. connecting to people's ability to do to do their job, a felt sense of peer support and connection, and ultimately fostering a sense of hope. So in psychological debriefs, when we talk about post-event team reflection, our primary purpose is not about the prevention of PTSD, but it is about bringing people together to build a sense of connection through this recognition of shared experiences, understanding decision making, connecting people with their values and this common sense of purpose as to why they came to work that day, and finding meaning around an event that might feel otherwise difficult to make sense of. And these psychological debriefs could be used after a specific event, or at any time that a staff team identify a need to come together to share to think about the impact that their shared experiences are having. So I hope that kind of I've been able to say something about debunk some of the myths that have been around for a long time about debriefs, but also be really clear about what we are talking about. We are talking about coming together as a group with this sense of connecting people around their shared experience, and they're reconnecting them with their values to hopefully find meaning and create a sense of hope. But if we stick with the literature, what we're saying is we know that needs to be in a broader context of staff support. So these post-event team reflections only really effective when we're looking at a full incident support pathway. So it needs to be part of a broader programme of support for staff. So you have your trigger event, which could be a patient death, it could be a challenging episode of care, it might be a rapidly deteriorating patient or a tricky transfer. In an ideal world, you'd have a hot huddle. Talk about the difference between a post-event team reflection and a hot huddle. So you'd ideally have a hot huddle on the same shift, certainly within 2 working days. And then you would signpost to further support for people in the team, for example, through occupational health or through a staff support service, if that's available. And then you'd have a follow-up space if required. So it may not be that an event requires a PETR 1 to 3 weeks later, but if it does, then there's the possibility of the capacity of that happening. This is a good example of what happens at GSTT, so thanks to the team there for letting me share this slide, but they would have an immediate huddle after a distressing event, which is usually run by a senior clinician. They would have a post-event follow-up, usually by their manager or supervisor, so the names of individuals would be taken down, there would be some follow-up, and then within 1 to 3 weeks there would be a psychologically facilitated debrief around that particular event. And I get asked a lot, what's the difference between immediate support versus later support? And I think it's just important to point out the difference that with a PETR, they're usually done between 1 and 3 weeks after an event, and they're led by a psychologist or a mental health professional. Now, you might co-lead that with a member of the MDT, but it would certainly be led by somebody with mental health training. They tend to last much longer, between 60 minutes, sometimes 90 minutes, if people have got can manage 90 minutes, but usually about 60 minutes. And importantly, they're generally only done with a single team. So you might end up having multiple PETRs about the same event, but all of the time at the core of a PETR, you're thinking about exposure to trauma. So you wouldn't have people who were very involved in a crash call, for example, alongside people who never saw the event happening, because of the risk of vicariously traumatizing people that weren't available, that weren't there at the actual time of the event. But if everybody was when I talk about a single team, I don't necessarily mean a team as defined by the hospital. What I mean by is a group of people that were involved in that particular incident. And then, so that may be a group of people that have never worked together before, but were all involved in that particular crash call, for example, that particular transfer. A hot debrief is different because it's ideally done on the same shift. It's led by a peer. It doesn't need to be led by a psychologist or a mental health professional, but it can be led by anybody in the group. And it very quickly addresses questions or identifies early actions and signposts to support. It really normalizes the emotional response to trauma that we've already talked about a bit today, and can function as an early check-in for staff. Sometimes it can have a learning focus and a wellbeing focus, but largely it addresses questions. It acts as an opportunity to signpost and can function as an early check-in. I also wanted to kind of just talk a little bit about how a hot debrief is different from an end of shift huddle, because again, these words are sometimes used interchangeably, but they're actually very different things. A hot debrief is ad hoc. It's around an event that's happened that has potentially caused distress, and any member of the team that was involved in that event might say or call the need for a hot debrief. It can happen, like I said before, on the same shift ideally, or within the hour of an event, and it's ad hoc, it's fact-based, it's not opinion, and its function is to contain responses, normalize, and to communicate. It's different from an end of shift huddle, which is built into the fabric of each shift and has much more of a focus on emotional well-being of staff. So it's really great when teams have these end of shift huddles, which is an opportunity for the group to come, the people on shift that day to come together to talk about to kind of just touch point, to be able to leave stuff at the like at work rather than taking it home. But the focus is very different, and it's built, like I say, it's built into the fabric of the ward team or the culture of the team. It's not an ad hoc event. If you need an ad hoc event after a potentially traumatic event, you need a hot debrief. So hopefully that's kind of helped people to kind of see the difference. But these terms are often used interchangeably, and I guess that's why I'm labouring this point a little bit. For anybody who's interested in setting up hot debriefs in their team or in their trust, I really would like point you in the direction of there are many different models out there. Time Out, it runs up in Leeds, particularly in an intensive care unit. So it's very sort of led by the intensive care unit up there, but it's a nice model. And then the Team Immediate Meet, it was developed by Julie Highfield in Cardiff, and the Intensive Care Society have picked this up. There's lots of, if you go to the web page on that slide, and these slides will come around so people can see them, there's loads of training resources for the team immediate meets. They're used in a variety of different settings, as you can see there. It's even used at Glastonbury, and I really would recommend having a look at the training tools and the resources that are available and free of charge, because it's very simple and easy to set these up in your workplace if you think that there's something that would be helpful. If it's useful for me to say, I think just really very briefly to talk you through what a team immediate meet might look like, what a hot debrief might look like. So as I've said already, anyone can use it who's been involved in the event. It doesn't need to be a lead clinician. It certainly doesn't need to be a psychologist. They need to be able to happen. I've got the privilege of working during the week and not at the weekend. I don't do night shifts. So a team immediate meet needs to be able to happen at any point in a shift when a potentially traumatic event has happened. They're ad hoc, like I say, they happen after an event. It's not mandated. The attendance at any of these kind of staff support interventions have to be voluntary. But It enables a team to stop, to assemble, and very briefly, within only a couple of minutes, talk about what's happened in a very fact-based way, how people are feeling, normalise the experience that it's okay to not be okay, to experience a range of very common feelings after an acutely stressful event, and then think about what additional support might be needed further down the line. You take the names of the team members and contact numbers so that they can have the opportunity for a check-in is possible, later on the following day or in the next few days. There's emphasis on this idea that it's really important to kind of put the event to bed before going to bed, in essence, so talk to somebody, writing it down, leaving it at work rather than taking it home with you, and helping staff to imagine what, if they were talking to a good friend, what they would need, how they would treat themselves as your best friend would treat you. Because I think we often find it easier to be compassionate to other people than we are ourselves. So it's really kind of a moment of pause to enable staff to kind of connect into what do they need now to look after themselves, given that this difficult thing happened on shift. So I've already said a lot of this. I'm going to be brief because I do want some time for questions. I'm saying that these different systems that we can have for supporting staff are really key, that they can be both preventative, proactive, but we can also have reactive strategies. So the preventative and proactive strategies are those that are readily available. How do we create workplaces and teams that people feel safe, calm, supported? They can access advice, support, practical help as needed. There might be some more targeted interventions that feel really important, like, for example, those hot debriefs after a particular event. It may be that it's useful to have buddying up, for example, with more senior or different members of the team. So there's opportunities for people to have somebody to go to or speak to if they've had difficult experiences at work. We've already talked about the importance of potentially building in wellbeing huddles or post-shift reviews. And then there's these kind of really important, as part of the picture, these spaces for people to come together to reflect on action in either a psychological debrief or in the moment in a hot debrief. I suppose this very last bit that I wanted to share with you is that I've been talking about different interventions that we can put in place for staff when they're exposed to potentially traumatic experiences or events that happen at work. But we know that well-being generally is much broader than that, and I'm sure people will have seen this. This comes from the King's Fund, and recognising that our well-being at work is much broader than just our ability to respond as leaders and as managers to particular incidents. It's about how we create environments that really support and bolster well-being right from the start. And I think it's just useful to highlight this, or hold this kind of triangle in our minds. I find it particularly useful. So thinking at the bottom level about kind of physiological aspects, I guess our basic human needs, like our physical needs, which is things like nourishment, security, sustenance, rest, routines, and what role we have as leaders and managers of people to create environments that means that people have the basics right, so that they're changing facilities, hot food at night, that they can access rest areas. This is stuff that will be really familiar to you, but it feels really, and perhaps maybe it seems a bit basic to be saying it, but it's a really useful reminder that that bottom layer needs to be absolutely right for people to have to be able to kind of function well at work, and to promote an environment in which well-being is kind of foregrounded, I guess, in our busy working lives. I always kind of like to think about, it's not just, I guess, on the wards, but I would imagine all of you have or lots of you at least, will have your work emails on your personal device. A lot of people will have that personal device in their bedroom or sleep next to their personal device, and possibly even wake up the following morning and look at their emails before they've even said hello to members of their family. And so whilst it's easy to focus on the kind of structural stuff around shift patterns or rota planning or restrooms and spaces, there's also the kind of broader ways in which we kind of we create boundaries around the kind of possible seepage that comes with having access to work in our personal spaces in a way that just didn't happen before the pandemic. So it's broadly thinking about how do we meet and maintain our basic physical needs, and how we kind of keep the boundaries in place around those. The structural part of this triangle refers to like the forms of inequity and injustice that impact on well-being, both personally and in the workplace, and the importance that we have as leaders and managers of recognising and acknowledging that we live in an inequitable organisation, and that really has an impact on people in the workplace. The cultural level of the triangle refers to the social and emotional quality of the workplace and the team dynamics. And that's this cultural piece is where things like hot debriefs, well-being huddles, post-event team reflection, opportunity reflective practice, that's where that piece comes in, that at the heart of our team, that people can say that socially, emotionally, it feels a good place and a supportive place to work. And then at the individual level, it's obviously the things that we can do for ourselves. And I've touched a little bit on that today in terms of thinking about our emotional regulation systems, being aware of what's going on for us at any one time, thinking about whether or not we're in threat mode, how we switch on our different systems to be able to counter the experience that we might be having individually. And in the last 2 minutes, I'm going to just really invite you to look at, and again, when you get these slides, to click on the link to this, again, this document that comes from the King's Fund that was produced in 2020, that's called The Courage of Compassion. And it really looks at what support is needed for particularly nurses and midwives in this case, but it's so relevant across the NHS, what's needed for people to be able to deliver high quality care. And it sets out these 8 recommendations designed to meet the three core needs that we have, which is about autonomy, belonging and contribution. And I think if we can hold these concepts in our mind, both for ourselves, but also for the teams that we lead, we're stepping forwards into a place that allows us to create workplaces for staff that helps them manage the stress and strains that they're faced with. So autonomy is the need to have control over one's work life, to be able to act consistently with our values. Belonging, we've talked about before, this sense of needing to be connected and cared for, valued and respected by the people that we work with. And contribution is the need to experience effectiveness in the work that we can deliver the valued outcomes. And I think, again, if we had more time, I would be really inviting you to think about you for yourself, but also for you and the teams that you lead and work in. Where do you have opportunities to increase autonomy, increase people's sense of belonging, and increase their sense of contribution? What are the systems and structures that need to be in place in order for us to be able to create the kind of foundations of good working environments that mean that people feel able to bolster the effects of the stress and strain of working in the NHS? So for frontline leaders and managers, what can you do in summary? I guess what I'm saying is create the space for reflection. Maybe that's about building in huddles at the end of shifts, or encouraging hot debriefs and PETRs after challenging cases. Model compassionate leadership, which is about acknowledging distress openly, sharing your own reflections to normalise the impact. Supporting autonomy, belonging and contribution, like I'm saying, that connecting in with the research that's been come out of the King's Fund. Spot the early warning signs for people in your team, noticing changes in behaviour and mood, and being able to proactively check in before there's a crisis. Knowing your pathways of support, so being clear about where that is for you in your organisation, and then embedding everyday well-being, encouraging, like really holding that triangle in place. What are the kind of bits that I have control over for my team that can really help to embed everyday well-being? And that might be about breaks, hydration, workloads, buddying up systems, and senses of appreciation. So thank you everybody for listening. It's been a whistle-stop tour. I am interested to hear your thoughts and reflections. What we're saying is that staff are going to be impacted. They will be impacted by the work that they do. There is a risk of trauma, burnout and moral distress, that we know productivity can be affected and compassionate care can be affected. If that's the case, it's really important to acknowledge it and to have both proactive and reactive support in place. It needs to be a range of different interventions. It needs to be part of a broad system of support, and that there can be specific tailored interventions that take place within that culture that promotes compassionate care towards staff. Everybody has a part to play in the MDT, but as leaders, we need to continue to think about how we standardise this so that it's available to all staff.